Welcome back, everybody. John Aravosis here with Cliff Schechter. And our guest today, you can see at the bottom of the screen if you're watching us on YouTube, is Dr. Craig Spencer, MD MPH. I'm assuming is that Master of Public Health, or what is that?
Yeah. Okay. I had to think about it for a second. I was like, wait, what does that mean? Yeah, Master of Public Health. Correct.
Is the Director of Global Health and Emergency Medicine at York-Presbyterian, Columbia University Medical Center. In English, that means he's an ER doc. He currently divides his time between providing clinical care in New York and working internationally in public health. He's on the board of directors of the U.S. branch of Doctors Without Borders. And we wanted Craig on today because he's been talking a lot about coronavirus, specifically what he and everybody went through in New York City, dealing with the crisis there as an ER doc, which I thought was really interesting.
Mostly because he doesn't just think it will disappear like magic.
Well, we're going to find out, won't we?
Therefore,
how do you know?
Exactly.
That's true. But at least if he said it would, I would believe there was science behind it. So yeah, he's an expert is what we're getting at.
Thank you for that confidence.
But your claim to besides the fact that I think you actually have better hair than me, which is really annoying because we don't typically Zoom. That's one of my Zoom rules with Cliff. I'm like, nobody can come on that has better curly hair than me. But I didn't even realize you were the guy until I was Googling you. I wanted you on because you've been really good on CNN and just really interesting and very no bullshit and taking on Trump with the stuff he's been saying. But last night I Googled and found out that Craig was either patient zero or close to it for the Ebola outbreak in New York in 2014 when you got back from Africa, helping with the crisis there, and you caused quite a stir in New York City.
Yes, indeed.
Did you know?
Quite a story. I didn't hear much about it. I was a little busy. I was in the process of healing. I spent 19 days in the hospital there. I was working in Guinea in West Africa, taking care of Ebola patients. And in the course of that, somehow, despite perfect adherence to PPE protocols, taking care of really sick patients, many of which die, is in fact a dangerous task. So at some point I got sick, and I was treated in the US. As you pointed out, and I think we shared this last night, at that point, Trump certainly thought that I was not an impressive gentleman. He called me a selfish man for my activities in that time. And yeah, I spent 19 days in the hospital, and thankfully,
so you had Ebola. So we're clear.
Yes, now, that is correct. I had and survived.
I mean, because
antibodies, yeah.
Because doesn't Ebola have a 90% fatality rate?
It's high. It's somewhere between 50, 70, 80%. It depends. But yeah, in the U.S. when treated, yes,
there's only like a 1 in 2 or 2 in 3 chance I'd die. So
it's like the flu, Cliff.
It wasn't 9 in 10. It's like the flu. It'll just go away. It didn't just go away. Then?
Don't worry about it.
Wow.
It's interesting because we talk about even just like the flu. The thing that I've been looking at a lot now is that we have this dichotomy, and we'll get into COVID, but like this dichotomy between like you survive or you die. 99% of people that get COVID survive. Yay, great. The problem is that we're seeing so many people, thousands and thousands of people that have these long-term continuing symptoms. And what I've been trying to highlight is the long-term symptoms I had as an Ebola survivor, because it's not just a COVID thing, it's a viral thing. Like if you get really sick with something, it goes throughout your body. And we've seen with COVID that it goes everywhere. It goes to your heart, your brain, every part
the
of your body.
myocarditis stuff we're reading is it's frightening.
And so my experience with Ebola and what we saw taking care of Ebola patients, those that were lucky enough to win the coin flip, is that many of them spent months, if not years, with lingering symptoms. So we're trying to use that one as a platform to highlight the fact that COVID is not just a liver-die dichotomy. There are people that are going to be continuing to live with symptoms long after this pandemic is gone because of their acute infection. And that's something that I learned the hard way from my bout with Ebola.
Can I say quickly?
Yeah, go ahead, Cliff. Yeah.
Well, no, I think this is really important, Craig. And I'm hoping, voices like yours on this exact part of the disease of this virus, but others, that we can get your voice out there, because what drives me nuts, and I'm just going to come out and say it and come clean, and I don't care if I piss people off. I grew up in New York, and I went to high school there, and one of the biggest voices, who's one of the let's call him a truther when it comes to COVID right now, is a guy I went to high school with. His name's Alex Berenson. You may have come across him on Twitter. Maybe you have. Maybe I have a lot of bad words I could say about him, and I'm probably going to say more of them in the future to him, because I've known him for a long time. I haven't been in touch forever, but it's people like him who are willing to demagogue, and it's because they want to sell books and do whatever they want to do. that need this kind of response, because all he does is sit there and point out, see, most kids don't die. See, nobody's dying. See, oh my God, this is ridiculous. And it's the long-term effects so much beyond who just lives and dies that needs to shut people like him the fuck up. Pardon my French, but it gets me angry because, I've lost a cousin to this and who was older, but I did. And I know a number of people who've had it, and they're going to have things with them for the rest of their life. And he plays in those gray areas. So whatever we can do to get your voice out there, please.
Well, to be fair, I think he has, and it's not just him. I mean, after him and I had a kind of a little back and forth on just this topic on Twitter, where he was kind of downplaying this, him and many others are basically saying, wow, if you survive it, get over it. There's not these long-term symptoms. It's a bunch of people that are just complaining and trying to continue this kind of this fear-demic of COVID. And then a couple hours later, Laura Ingraham chipped in with her ideas, asking for science, which I thought was interesting because she clearly has never asked for that before. And so, I think this is just one of the further next steps. It's like when we try to highlight an issue that is in fact an issue, the fact that people continue to have myocarditis, neurologic sequelae, Guillain-Barré syndrome, there's like all these things that we're seeing that are linked to this virus. It's not because any of us wants to fearmonger. It's not like I want to continue going on CNN or you know what I want to do? I brew beer. I want to go back to brewing beer and spending time with my family and then like watching a movie and reading a book. I'm reading the same book I picked up in person at the New York Public Library 7 months ago.
Okay, so you live in New York.
Talk about this, yeah.
Your wife's from Cincinnati. I already thought I liked you, and now you're brew beer too. What is this like? Frickin'? Did you read my bio? No, I'm just kidding. Go.
That was my initial goal. I'm going to go in and I'm gonna open a brewery, going to brew some beer. It's going to be great. And then I got into public health, and I wanted to work internationally. But and then this is where I'm at teaching. And
I'll just the one quick thing I'll say, and then kick to you, John. The reason I brought up Alex is he's more dangerous though, because Laura Ingraham we expect this garbage from, and granted they talk to the believers, and that's bad. But Alex has the whole background of New York Times reporter and all the kind of liberal institution stuff, so he can convince more people, and that's why I love to have your voice out there. But in any case, I'll kick it to John or you.
Greg, have you found, is this unique in terms of the amount of sort of disbelief or skeptics or anti-coronavirus people, anti-maskers, et cetera? Have you noticed this in medicine before to this degree?
Yeah, what's interesting is that, in 2014, 2015, when I was in West Africa, we heard a lot of the same stuff, right? We heard that this is a hoax. It's a rumor that it's being used as a political tool. This is one of the most common retorts that we heard in West Africa. And I thought it was interesting then, because here in the US, we talked about kind of like ignorant Africans that couldn't quarantine for just a couple of weeks to get this under control in Monrovia, or these people that, aren't smart enough to recognize that this is a real disease, or aren't willing to change their culture so that, they don't have to go to burials where people are getting infected. And I think it's interesting because we're hearing all of the exact same things right now that we maligned and we denigrated others for just a few years ago. And so I think the parallels are so poignant.
It reminds me of AIDS in Africa.
Sure. Yeah.
All the crazy stuff I'd worked on in the 90s. There were all sorts of crazy... Okay, AIDS in Africa in the 90s. If you sleep with a virgin, it'll cure your AIDS.
Oh, God.
No joke. No, that was one of the big problems.
I remember.
Because it then started spreading the virus more, but all sorts of denial.
In South Africa, for sure, yeah.
Yeah, sorts of denial.
Still in the U.S., right? I mean, there's still, we can't expect that 100% of people are going to be 100% knowledgeable of all these things, especially with something like COVID, right? In the past 6, 7, 8 months, we've had tens of thousands of papers that have come out. We've had a bunch of interviews. We've had a bunch of experts emerge in a disease that no one is really an expert in. It's really hard for me, as someone who basically commits my full time to this, to process and sort and triage and see what is important. How does this change the trajectory? I can't imagine what it's like for kind of a passive consumer of news, someone that's on social media or scrolling New York Times or Fox News or whatever it is, to get the right information. It's nearly impossible to know who's an expert, who we should be listening to, what bit of information should undermine or overturn that long-held belief we've had for the past couple of weeks or past couple of months on something.
Right.
So the goal is we need to recognize and we need to support public health experts who don't have an alternative agenda, right? Like, I don't have an alternative agenda. I've made exactly $0 from the hundreds of hours that I've put into writing, going on programs like this. Like, my goal is not to write a book. My goal is not to do any of that.
You didn't get the payment from us?
George Soros, the George Soros payment.
You didn't get our George Soros money?
Yeah.
We pay in George Soros bucks, actually.
Exactly.
They have his face on it. I'm just kidding.
I'll invest that in the future. No. Anyways, the point being, like, there are people that clearly, as you pointed out, John, like, clearly have an agenda in this. The goal is to trust and understand that there are institutions like the CDC, like the WHO, who have had an agenda for decades, and that agenda is to save lives, not just in the US, but all over the world.
Do you trust CDC and FDA right now?
This is tricky because do I think that there are tens of thousands of civil servants working at the CDC and the FDA that are doing their job and highlighting the science and doing really good work? Absolutely. Do I have concerns with the way that the CDC and the FDA have been politicized over the past couple of weeks and past couple of months? Absolutely. I mean, think about what happened early on when I think it was Nancy Messonnier basically said, hey, schools might need to close. This is going to be tough in the coming months. And from that point on, CDC basically hasn't been in front of the public.
Yep.
In the past few days, maybe we've seen a little bit more pushback from Robert Redfield. I don't know what's going to happen. Maybe people at the CDC or the FDA could en masse resign one day, but that might be a news story for 6 hours or 8 hours before some other
Trump will tweet something crazy and
some other dumpster fire emerges. But I trust the science. I trust the people doing the science at both those institutions. They are really great. They're committed. What I don't trust is kind of the political pressure that's being put on them by HHS, by Alex Azar, by Caputo, who just had an inglorious exit. So it's hard to say. There's really good stuff that's coming out. What's going to happen in the next couple of weeks, the next couple of months when we get a vaccine that comes out? Is it going to be influenced by some political arm twisting? Yeah, a lot of us have that concern.
Right. And I'll just say, I don't know if you have kids, but having kids, my wife and I have never felt like this before, which is, we're consumers of news. And we follow everything. We're believers in science, and yet still, we don't always know what the right thing to do is for our kids. We don't. It's a frightening feeling, right? You can't trust your own government, and certainly, unless we're going to have them guzzle bleach, we're not trusting the guy at the top and what the hell he's saying. And I don't know how to put it better than I've never felt this way before. So much like I'm doing my best as a parent, but I don't even know if that's good enough. I'm trying to make the best decisions on whatever information I can find. And people
it makes
like
you feel any better. I feel the exact same way. I just put my kid back into daycare yesterday, and I'm like, I feel good about this. Like, it needs to happen. I think for her, and because we're in New York City, where the test positivity is less than 1%, and they've been open for 6 months, and it's been okay. But like, it's all of this is a gamble, right? And we should have that science. We should have that precedent being set up top. We should have, and we haven't talked about this a lot, but like, we should have social media platforms that are being responsible, as opposed to kind of highlighting that fringe. And the fringe may be the mistruths that come out of the president's mouth on a daily basis, but it's also, using that algorithm to push these peddlers of false information, these snake oil salesmen, these charlatans that are
You're not speaking about one social media platform in particular, are you? I'm not saying they all don't have it, but there is one that's worse.
I did write a New York Times opinion piece a couple of weeks ago with Dr. Seema Yasmin about one particular platform you may have heard of. No, to be honest.
Does it rhyme with Hacefuck?
You may have heard of it. Yes. It's just like, it's a disaster. It really is. And I'm not on Facebook. I got off of it in 2015. But even, what I see on Twitter and on Instagram, like, I get it. It's really hard for parents, or for people, or for public health officials, really just to sift through all of this, try to get clear, consistent messaging when that messaging is going to change. Like, we've evolved on things that we didn't know, or we thought we knew in March and April and May. It's our job to be really good communicators about that. But like, I can go on CNN on a program that gets, 1 million viewers, 2 million viewers a night. But then there can be a viral Facebook video that can be seen 20 million times in the span of 24 hours. Like, what am I going to do about that?
Right.
Could you take us back to March, April, New York City? You're an ER doc. You guys Take us back to like right before the flood happened. So you're expecting, you're hearing dire predictions of what's going to happen with people coming in with COVID, but you're not seeing them yet. Take us through, like, did it all just happen in a week or two? Was it a month of slowly ramping up to horrible, or was it literally in a week or two you went, oh my God, what's going on? I mean, what happened? Was it March, by the way, as well? Like, when was it?
Yeah, for sure. Yeah, I mean, so New York City's first case was March 1st. We knew that there was cases that were circulating before. And then I had written an op-ed, I think in mid-February, like ready to go to be like, all right, as soon as we get the first case in the next couple of days, I'm going to push this out. And it didn't happen for weeks. And so we were all kind of surprised. In the Spencer household, we were definitely a little more prepared than the others. My wife had kind of gone through this before. So she was a person at Trader Joe's and like early mid-February with 2 big carts full of stuff, like, haha,
is she a doctor
get this? No, but she's married to a guy
one.
Had Ebola.
No, I know. I just
like, I know what's going to happen.
Ebola.
Right, exactly. We've been there.
And everyone's like, who is this crazy person? We won.
Yeah.
No, so at that time, like I was ready. I kind of, I had been listening to what was happening in China in January. I had friends of mine that were living in Beijing at that time that I was in touch with, and they were like, hey, this is crazy. This is weird. Like, y'all should be prepared for this. I started wearing a mask basically the whole time I was in the emergency room in February. And it wasn't until really early March that I think we saw kind of our first case in my emergency department of COVID. And I remember there being this kind of like kerfuffle and everyone a little skittish about like, okay, what to wear a mask, what medicines can I give without worrying about nebulizers, like all that stuff. That the first time you see something that there had been protocols put out, but you were a little unsure of. I had worked with scary diseases before, so I felt a little bit more prepared. I felt comfortable in my personal protective equipment, but like most doctors don't wear N95s almost ever. And so getting everything on, making sure you feel comfortable, that was tough for a lot of people. But it was really within the span of like mid-March, I would say, from like 15th, 17th until the time of like the 24th, within that week, where it went from having one patient in the emergency room or knowing that 1 or 2 of them are likely COVID positive to trying to find the 1 or 2 people that weren't COVID positive. Like there was a week of like massive turnover, and it went from everyone was a little on edge, what's going to happen, to sick patient coming in, sick patient coming in, sick patient coming in, sick patient coming in, getting intubated really, really quickly. Yeah. I mean, it was, I want to say overnight, but over the span of a few days and over that week, it basically flipped. Yeah.
How do you deal as a doctor with the deaths? And let me put a finer point on it. How do you, because I've always wondered this about medicine. I'd thought of going into it, but it's one of the things that would have worried me was, how do you stay dispassionate enough that the deaths don't burn you out, but not be so dispassionate that you're just kind of a bitch? That you're just this doctor who doesn't care. But if you care too much, I can't even imagine going through what you guys went through. You were talking on CNN about you had to do those Facebook or FaceTime videos with family members dying and things, right? I mean,
yeah. I mean, pretty often. Like that was something that we all had to do.
New York.
New York.
Yeah, exactly. Just filter it. Yeah, exactly. Like the MLB games, we just put in a little background sound.
He's not even in New York. He's got like a little tape recorder in the background. Honey, play the buses honking.
He's somewhere in Montana pretending.
Exactly, at the ranch.
Get off the road. And no. There's, John, it's not either or of those, right? Like there are times that deaths impact me much more than others, and it may be within the same shift or kind of back to back. For a while, I thought maybe having worked in West Africa and seeing people die every single day from Ebola during that, maybe that in a sense desensitized me. I don't know that it did, because definitely during COVID, there were times when, I was standing at the bedside of someone and calling their family and basically saying like, this is the prognosis, having this really long discussion around what were his goals? What would he want? Did you have these discussions beforehand? Like, what is this something that your father, your brother, your sister, your loved one, your worst enemy would want? Having these discussions, and oftentimes the decision was to withdraw treatment, and that meant turning off a ventilator and just standing by, holding someone's hand for them to die, and that's something we did a lot. And even just talking about it, obviously it's really unsettling. And that's nothing compared to what it was like in the moment. I don't think you get used to it, but then another one comes and you need to be prepared, and another one comes and you need to be prepared. And so I think that we find a way to kind of mentally space that off and
compartmentalize it, because you have to, right?
Yeah, but like at the end of shifts, or in my days off, colleagues of mine all over the city would call crying, because for a lot of people this isn't what they thought they signed up for. Emergency medicine, we're there. We are, whatever happens, whatever you put anywhere in your body or whatever you fall from, we are there to help you. We're there to save lives. And for us, it was tough because we were standing by and watching lives pass. That's not something we do. Yeah.
Let me ask just real quick with that. How many deaths normally would you see in a week as an emergency ER doc, and how many were
0.
you seeing at? Oh, really?
Maybe 1.
Oh, wow.
Yeah,
See, I think we're used to watching TV shows and thinking it's the emergency room. You're going to lose somebody every day.
Well, it also depends which emergency room, where he is.
Right, exactly. Yeah, sure. If it's if it's a level 1 trauma center, if it's a place that's getting a lot of gunshots, or if it's in for sure. I mean, I've worked in places in East Africa in the middle of a civil conflict where I saw multiple people die on a daily basis. In West Africa, multiple people die. But in the US, no, it's pretty rare.
So how many were you seeing? How many would one doctor in your practice, how many people would one doctor in your practice see die in 1 week during the height of COVID in New York, compared to the 0 they might normally see?
Yeah. I mean, there were days where it was multiple. I think one day there was 5.
One day?
Yeah, and then you multiply that out by however many days a week. Not to say every day it was 5, but even if the next one was 3 and the other one was 2, I mean, by the time you're done with a week, God.
Wow.
I mean, during the height of it, it was pretty rare to go into a shift and not have somebody die.
I just didn't realize you had such a minimum number of deaths. That's what surprises me. That
we're good at what we do.
It really was such a chasm. No, but that's great. But I think as a civilian or whatever, I guess I mistakenly think that doctors are used to people dying on them, and they don't have nearly as much practice as or experience.
Some kid putting a coin up their butt, or that kind of stuff.
Yeah, Cliff, not that Cliff has any idea what that's about.
No, I never experimented in that way. I promise.
It's okay, Cliff. We all do. The thing that we don't talk about, we think about this, and it's true in emergency medicine. We get people that are really sick, and we stabilize them that ultimately will die in the operating room, or will die up in an intensive care unit hours or days later. Our job is really to stabilize and get them to the point where they can get that definitive care. But what we saw during COVID, in addition to all the deaths that we were having, our EMS crews were going out every single day to dead on arrival. And it wasn't just 80-year-olds, it was 30-year-olds, it was 50-year-olds. I remember one day a friend of mine tweeted what looked like lotto numbers. And he was like, these are not, lotto numbers. These are the ages of the 5 people that I saw dead today when I went into their apartment, and nearly all of them were suspect COVID.
Oh, in one apartment?
No, in multiple, during a shift.
Jesus. All right, yeah.
But we did see that too. That was one of the issues, right? Like there was multi-generational families in one apartment. So if one person got sick,
small quarters,
other people got sick in small quarters. Yeah.
Well, that Italian family in Jersey. Oh my God, that was early on. Remember, like 19 members of the family got sick because they held some big family dinner or something the week before. The mother died. Yeah. 3 of the children died. I mean, it was just horrific.
Jeez. Yeah. But, so the death was horrific. It was, I don't think anything that we got used to. And I think, quite honestly, it scarred a generation of my colleagues it created a lot of kind of mental burnout. We had colleagues that died.
I saw that like there are 1 or 2 right? There are a few suicides even. I mean, it was heartbreaking. Yeah.
Well, something positive, so to speak. The death rate seems to be down significantly as a percentage. What do you call it? Is the morbidity? What do you call it? When the percentage of people who get sick who die?
The case fatality rate.
Case fatality rate seems to have gone down significantly in the U.S. We're still having a lot of deaths because we're having so many cases. But does this case mortality rate going down, the percentage of people who die, who get sick, does that mean that even if we have another wave, which everyone expects in the fall, that maybe you won't get as inundated? Or is there still a lot of fear that you're going to get inundated, just like you were in March?
I mean, Right. I mean, it's hard to say. So you're right that the likelihood of people dying from COVID because of our, increasing knowledge about how to treat it, how to, vent settings, about a couple other medications, the likelihood of dying has decreased, which is, I think, is part of the reason that you're seeing fewer deaths from it, although we're still having over 1,000 deaths a day for like 9 straight weeks, which is pure craziness. It's hard to know what's going to happen in the next couple of months, and it's hard to know how that's going to separate out, cases from deaths, right? Like the cases can certainly spike up. We'd likely have fewer deaths in November than we did in March and April because we're better at treating the disease. I don't think that means that we're not going to have more deaths going forward. I unfortunately suspect that we'll continue to have a pretty high baseline of people dying from this until we have, measures to get this under control, until we have a vaccine, better therapeutics, and those are all in the works. But it's hard to say. I don't exactly know what's going to happen. My suspicion is that we're going to get more cases over, starting in the next couple of weeks, and that's going to increase. We've seen, with schools,
as people
with
are more
college
indoors,
campuses, as people are more indoors. I suspect that those case numbers will increase. I expect that we'll continue to have a high level of deaths. Will that likelihood, that likelihood of dying from this continue to further decrease as we get better therapeutics, we get better knowledge on how to treat it? I think so, and I hope so, but I don't think that's going to be sufficient enough that we can save every single person who has severe COVID by any means. There's still going to be people that end up getting intubated that have really severe multi-system disease from this, and we're going to continue to die.
And isn't some of the reason why, that the morbidity rate has fallen, the percent, because we've now had a lot of these cases spike at kids returning to school in colleges and, and other schools, so that they're younger and obviously they're less likely to die than older folks. That probably contributes something to this. Is that right?
Sure. Yeah. So what we know is that there's been a bunch of outbreaks on college campuses already, thousands and thousands of cases. If those are confined to college campuses, that's one thing. There are still obviously teachers that can get sick from this, or other staff that are there, people that can get sick, that are getting sick. In addition, as we talked about, like getting infected with this, even in your 20s or 30s, is not innocuous. Yes, the overwhelming majority of people get this, survive, and have no sequelae. Great. If even a small fraction of 1% have longer term symptoms that last for weeks or for months or even longer, that's a problem when you have millions and millions and millions of people getting infected with this virus. So I think what you're saying is, like, we kind of have the morbidity rate.
Now. I'm not saying, no problem, it's just the kids. Yeah. Like, I was more getting at that might be a contributing factor to why fewer people are dying from it, because the age range is but it's still terrible. Right. I'm not trying to say it's,
No, for sure. No, but I think you're making a good point. And I think you mean what you mean. It's like the mortality rate, the likelihood that you die from this. The morbidity is so high. The morbidity is like you're having symptoms, it impacts you, it affects you, but you might not necessarily die from it. Mortality,
I'm messing
the likelihood that you die. No, it's okay. That's what my job is. I'm here to clarify. But the mortality, you're right. Like if you have a bigger proportion of your cases in groups that are less likely to die from this, and younger people are definitely less likely to die from this, the likelihood increases after 55, 65, 75, 85. If the majority of your cases are in a younger population, in your 20s, like on college campuses, the likelihood of death in those cases is going to be lower, and your death toll from those outbreaks is going to be lower. But what we see from those is those are potential seeding events. You're just as capable of sharing that with your friends and sharing with that your teachers. Right. And if colleges, for example, close down and decide that they're going to disband and send people back home, or people are in communities, like this is when we've seen this before. We saw this a couple months ago when we had an increase in infections in younger people in places like Florida and Arizona, and that those caused other infections in people that were more susceptible to having a severe outcome from this.
Are you seeing complications with the young people you're seeing in your practice?
Absolutely. Mm-hmm.
What kind of things are you seeing personally?
Yeah. So a lot of what we see, and
I'm saying somebody under 30, say, who's otherwise pretty healthy.
Yeah. I mean, it's pretty often, at least every couple shifts, I see someone that has what we're calling long COVID or chronic COVID symptoms, and it may be that they're continuing to have some shortness of breath, something we see very often. Colleagues of mine have talked about how 6 months ago they survived the infection, they were pretty sick, but still they're unable to walk up a hill. These were people that were doing sub 9-minute miles in early
Jeez.
March. Now can't even walk up a hill right now.
Do we know what's causing it? Are the lungs actually damaged? Are they inflamed, or do we not even know?
We know some. So we know a lot of background from SARS and MERS, which are other coronaviruses, kind of like COVID cousins, the SARS-CoV-2 cousins. And they cause long-term pulmonary, so lung, cardiac, neurologic sequelae in a lot of people, actually.
So you keep saying sequelae. What is that?
Oh, just like these longer-term complications.
Okay.
Yeah. So basically what happens after, because we talk so much about like you have COVID and then you're over COVID. Like if you get the flu, you feel like crap for a while, right, and then you get better. And the majority of the time you get better. It may take a couple of days, maybe even a couple of weeks until you feel back to normal.
Right.
But there's a lot of people with COVID that doesn't end in a couple of days or a couple of weeks. It's going out for a couple of months. And so these longer term complications, we're starting to learn a lot more about it. There are research studies that are being done, a lot of them by patient groups themselves who were just sick of getting gaslighted in doctors' offices and emergency rooms, where people just being like, I don't know what's wrong with you. Yep. Maybe it's anxiety. And so we're hearing a lot of that as well.
I got a question for you. So, Cliff, I don't know if you saw me tweet this yesterday, but I was going to ask somebody, but you're the perfect person to ask because I want this to be educational for everybody. I go to a doctor's office in DC, not going to say even which kind of doctor it was of mine, and the mask rules and everything else, sitting in the waiting room, and there's a gentleman across the way with his son who decides he wants to drink his sippy cup of coffee, pulls his mask down, and for the next 15 minutes, he's drinking his coffee and reading his phone. I'm kind of freaking out. I go and tell the front desk. Of course, one of the receptionists has a mask. The other receptionist doesn't like to wear hers. And told them, and they told me, well, he's drinking coffee. And I mean, you can imagine. I mean, I can tell, like you're Mr. Civilized on TV, but I could tell, what I was like ready to say, like, really, the fucking virus doesn't kill you if you're drinking coffee? And I went, excuse me?
It's killed by the cafe fumes.
Yeah, the cafe fumes just, it's so lovely, especially with a fine roast. So I was like,
if that was the case, what happened in Italy, right?
I took a picture and sent it to the doctor who was in the other room. I was so pissed off. She finally comes out and goes to the guy because she could tell I was pissed. And she whispers and kind of looks at me and goes, and he goes, I'm drinking coffee. I was just like, oh my God. And this wasn't.
Then don't and wait until you drink coffee till later.
So she told him he put the mask back on, but I'm like, A, what the fuck that there's coffee exemptions. B, several people in his office were not wearing masks. So the staff are they supposed to wear masks? Like generally speaking, am I not wrong about this? You've got it right.
I
mean, it sucks all day to wear a mask, but if you're in a medical environment or shouldn't they? I mean, I just was like. Oh,
I mean, I would imagine one, of course, for your safety, but also for the safety of others. I would imagine it clearly wasn't a hair doctor that you were in, but regardless of what it was, there could be a population. there could be a population that is more at risk, and I think this is part of the messaging that we need to do. Right, like it's not just if you're in your 20s or your 30s and you're working in a doctor's office and you're unlikely to have long-term symptoms from this. That doesn't mean that you can't pass this on to other people, and we're seeing that this virus is like so crafty in how it passes around in a lot of people asymptomatically, especially
I could have gotten her sick. How does she know that all of us all of us, we're not supposed to come in if we don't have symptoms? Yeah, like that helps.
Yeah.
No. I mean,
well, to me, it's just it's selfishness that we're seeing out there these days. Is wearing a mask fun? No, it's not pleasant. It sucks. Was my wife's grandfather going to fight in the Ardennes in the middle of the winter against Nazis for his country fun? And then he got shot a couple times? Probably less fun. And he did that for you can't wear a fucking mask for your country. It's incredible. All of it to me. But
yeah, well, I mean, this is an issue we can talk about for years. But I mean, I think all of this goes back right to the precedent that should be set by the president. And we actually have higher rates of mask wearing than a lot of other countries, right? And that's increased,
really,
not just among Democrats, but also among Republicans recently. Yeah, I mean, there are the majority of people on both sides report that they're wearing masks. Whether that's actually true, it's hard to say. Okay. But we do like to talk so much about the fringe opinions, right? Like the teens running through Target, screaming about how masks are repressive as opposed to living in a repressive society with institutional and systemic racism. And
but who's counting? Yeah,
right.
but who's counting? Same, I imagine. No, but there is people, despite kind of the noise and the lack of precedent set and good public health policy by this president, I think the majority of people know what should be doing, know how we should stop the spread. Some of them are going to comply with that, and some of them are not going to care. I don't think it's as dismal as we often and almost always say that it is. It certainly could be better. I think that's evidenced by the fact that we continue to have an outbreak across this country. But I think that's just, again, more messaging that needs to be done to target those groups to say, hey, look, I know you're a 20 or a 30-year-old and the likelihood that you're going to die from this is low, but the likelihood that you could get infected and pass this along to someone that you're working with on a daily basis is pretty damn high. And that's hard to do.
Thousands of adults attending an indoor rally for Donald Trump in Nevada. Can we message them in any way you can think of?
Yeah, I can think of ways we could. No, it's frustrating, right? Like, because especially within the past week, hearing the Woodward revelations, they weren't all that revealing, quite honestly. I think that this is not at all surprising to any of us who have. He lied. Well, not even that he lied, that he knew things that he said he didn't know. Well, we knew those things. We've been talking about those things for months. That's what people like Fauci have been getting up and saying. But since day one, that message has been deliberately undermined, making it impossible or near impossible for other public health experts to get up and share in a nonpartisan way information that should be nonpartisan. Because every time, and I get this all the time, Craig, you're being political. No, me sharing public health information, trying to counter the lack of public health information from a political official is not me being political. It is me doing my job as a public health person. And even that's
what I can't stand the most is they throw things into the political realm, whether it's climate change or gun violence or whatever it is, that should never be there. That should be in the medical realm or the scientific realm. And then if you just give correct information, no, shockingly, having an unsecured gun in your house is not more likely to keep you safe. Shockingly, climate change is actually happening. Take a look out west or whatever it is. I don't want those to be political issues. Those should be about the science, but abortion rights would be another one I would go with, and women's health. But, they do this. And then suddenly just someone like you sharing the truth, which shouldn't be political, you get accused of being political. It's ludicrous, but it's also where we are.
Yeah.
That's our happy sound. We always have such happy podcasts.
Whenever there's quiet because we've said something that's like a little depressing.
And we all kind of get
damn, bunch of downers this morning.
But anything positive?
Give some positive news.
No, but is there anything that gives you hope? And I don't mean your baby. Is there anything in terms of what you're seeing on the horizon? And I don't mean this facile either. Like, the vaccines are coming, because who the hell knows if the vaccines are coming, right?
Correct. Yeah, we don't know.
We're getting
there's a good
news,
chance.
But go on.
Yeah. I'll talk a little bit about vaccines, and I'll, in the meantime, try to find something that I can end this optimistically. No, yeah. Let me.
Do you know any good jokes?
Yeah.
A couple doctors walk in a bar. Go ahead.
No, they wouldn't. They would never do such a thing. I think that was a good one. In terms of vaccines, right? Like we don't know. There's a bunch of vaccines in the pipeline that are looking at different aspects of how this infects and how this, evades the immune system and how it replicates. Like, there's a bunch of different approaches to this. And I feel pretty confident that we're going to have at least one that's pretty decent sometime soon. And by meaning that we'll have one will have gone through, decent scientific analysis, likely by the beginning of early next year. And we'll have an idea that hopefully it's like 50, maybe 60% effective. There's going to be other issues with it. There are going to be others, hopefully, that come after it that are better, that may only need one injection, but as you pointed out, John,
so it won't just be that Trump tested it on Tiffany and decided that it could work on?
I think he's going to test it on Don Jr., Cliff. Come on. and Melania.
Right? He said his daughter took it, so it must be good. And so thousands of people in Russia are getting a vaccine trusted on his daughter. No, there is my hope. I feel optimistic that we're going to have something. Now, by the time that gets to people like either of you, it's going to be a long time after that.
Middle to the end of next year, probably, right?
Hopefully.
Yeah, I mean, making a vaccine is hard, but the process of like putting it in medical grade glass and getting it out and distribution is massive. Like,
okay,
massive.
Explain that, because I wanted to ask you something along those lines. We hear them always talk about how, to do these vaccines, we're going to need syringes and needles, and we're all going, don't you have syringes and needles? Like, what is this whole? I heard that idiot doctor in the White House that Trump got from the Federalist Society, or whatever the hell it is. Yeah, that he was going on yesterday about. A reporter said, well, but you're going to need like nitrogen refrigerators or blah, blah, blah. And most offices don't, they're all going to have that. And I was going, you need some special super cool
herd mentality.
But I mean, what is
herd mentality?
Why is it not so obviously easy? I go to my doctor, I get my flu shot, it's easy. Why is it not easy?
Because we're going to try doing this at a scale unlike anything that's been done before, right? Just like COVID has hit us at a scale unlike, anything in the past century. You're going to try to vaccinate hundreds of millions of people as quickly as possible. And you need to make sure that, one, the quality of these vaccines as they're coming out of production is consistent and is high, at a really, pushing these out and creating manufacturing at a really, rapid rate, getting them in the glass, getting them into people's arms. Yeah, you're right. Like, refrigeration for many of these are going to need to be held really, really, really cool. They're not going to be heat stable. They're going to have to be refrigerated until the point that they're actually injected. Offices themselves, how do you get the vaccine and how do you make sure you have enough of it for the people that are kind of in your practice? Are you going to be doing this in parking lots? Are you going to be doing this? There's been this idea of, doing it in big arenas, having these kind of mass vaccination events. Like, doing this for a small outbreak in a small area is logistically a lot of work. Doing this across the country for hundreds of millions of people, prioritizing who's going to get a limited supply at first, is going to be a massive lift. There's going to need to be a lot of commitment, a lot of resources, a lot of funding to do this from day one. I will say, and I've been quite critical of this administration's response to COVID, mostly because I think there hasn't been much of one. But the one thing that they have done is they have poured billions and billions of dollars into getting a vaccine. I think it's.
I wonder why.
Yeah, I wonder why. I mean, but I think it's also quite reflective of the American approach to healthcare, right? Like, hey, you know what? We could do this in a much cheaper way, but
if we prevented it, but screw preventing it. Let's just get there afterwards.
Let's tear apart the pandemic preparedness architecture in the country. But what we can do is put billions of dollars into a vaccine push. But that being said, we will very likely, I feel pretty optimistic that we'll have a vaccine in record time. I think that, with a commitment by pharmaceutical companies that they're not going to release anything that is not based on science, it's hard to trust pharmaceutical companies, quite honestly. But I think that they have not only a short-term, but a long-term investment in this as well. If this vaccine rollout gets messed up, if there are side effects that come out later, or if there's anything untoward about this is going to undermine kind of vaccine uptake and vaccine use in the country for a very long time.
I would think would suffer in a pretty serious way if they're associated with something like that. So let me ask you this.
Can I ask you one more vaccine question?
Yeah, go ahead.
And then, I'm sorry, and then, because this is the second thing I wanted to get was, and I realize you are not necessarily a vaccine expert in the sense.
I'm not a vaccinologist. Right? That is
You're not an immunologist or whatever. But my question, though, and maybe you know this just from being a doctor, from being an MD, why is there any risk at all with vaccines? And what I mean by that is, I think us lay people, again, we think, if you're using a weakened virus in the vaccine, there's a chance the weak virus takes over and becomes a real virus. Okay, I can understand that. But I've never understood all the other discussions. We're hearing about these different vaccines being based on a piece of RNA is in the vaccine, or something that grabs onto the shell of the virus. It's stuff that itself cannot create a virus, so there's no risk. And it's a procedure that's been used before. So why is the only risk efficacy, that it doesn't work, and not there's actually a medical risk of it causing harm? How can these vaccines cause harm if you're not using a live virus?
That's a really good question. That. No, I mean, that's a really good question. And you're right, I'm not a vaccinologist, but what I can tell you is that, so some of these things like the Moderna, and there are other companies, but the Moderna is the furthest one along, is an mRNA vaccine. There has never been an mRNA vaccine that has been brought to market and has been used. It sounds quite promising. It may be one of the first ones that gets released. We don't have a lot of experience with it, quite honestly, with the technology. Is it likely to be quite safe up until to today? It has been. We haven't seen we haven't seen side effects, but we don't exactly know. With others, some of the vaccines are using technology where they put basically little parts that look like COVID on other viruses that the body can see and are not going to be really severely impacted by. This is a long used technology in vaccine research, but none of this is foolproof, right? Like, we know that even when you give regular vaccines, there could be a 1 in a million chance that there's an untoward effect. And this is true for all vaccines, right? Like, the vaccine causes some immune response, and in some people that might be hypervigilant. It might be different than it is in the majority.
Well, you got me thinking of the cytokine storm issue, which I hadn't even thought of. But the issue, one of the concerns with COVID has been that your body reacts so forcefully to fight it that the overreaction of your body starts to, I guess, attack your organs and everything else.
Right.
So I never thought of it that way, that what if the vaccine causes something similar? It causes your body to overreact in a way that's damaging, right?
That is certainly a possibility.
Okay.
That's possible.
That's interesting.
Yeah.
That's interesting.
Kind of, the fact that, and we've seen this with other vaccines where, getting the vaccine can in a sense prime your body. So if the next time it does see that, it actually has more of an aggressive response. And so, yeah, these are all concerns. Okay. Are they likely to be huge and kind of deal breakers? No. But again, if there is a 1 in a million side effect from any of these, it's hard to know, even in really well done long clinical trials and the decades long process that we sometimes do. Right. It might be a little bit harder here, but even if there's a 1 in a million outcome, if you are ultimately vaccinating hundreds of millions, if not billions of people, there can be, and there likely will be some impact from this. The question is, the risk versus the benefit. We know that.
What's acceptable risk when it comes to, I read something that said 1 in 13 million, and I don't know if that's a random thing I read or I don't know. You tell me.
I think that changes with the pandemic. I think that calculus has to change. And I think we've seen that with the FDA, right? Like, they've changed that calculus around convalescent plasma and other decisions that they've made, because in a pandemic that's killing hundreds of thousands of people, right, you may be willing to accept a little bit more risk on things. So
convalescent plasma they did because of Trump, actually. Remember what happened there? I don't mean to correct you, but what happened there there was a press report 4 days before that the FDA or whatever wanted to move ahead with convalescent plasma just to try it. And Fauci and some other senior people jumped in and said, no, there's not enough data. We're worried about this. And they said, okay, let's hold off. 4 days later, Trump weighed in and forced them to approve it. And now we're finding that it's not really working, I guess, is what we're finding. Surprise, surprise. Yeah.
It's hard to say. I wrote a piece in the Atlantic about convalescent plasma based on my experience.
Tell us. Actually, tell people what it is.
So basically what it is that you take the serum, you take part of the blood from people that have survived a disease, and you extract that, and you put that into someone who is currently infected with it. The idea being you're basically pulling antibodies from a survivor who has made them, putting them into someone else who is currently fighting that disease. The idea being that you can build up their army, right? You can throw antibodies in their body that are going to help them. It's great. It has been used for over 100 years. It has helped respond to measles and diphtheria and a bunch of other things before we had antibiotics. It's not innocuous. And this is what I wrote in this Atlantic piece, because I received convalescent plasma for Ebola, and it did not make me better. It actually made me worse. That's unlikely. The majority of people that get it are perfectly fine. The safety data on it is actually, it's quite safe. And so in considering this, part of that back and forth between the NIH and the FDA and the politicians who are determining whether or not to use convalescent plasma, part of the calculus is we're in a pandemic. So we need to have more things. The safety data on convalescent plasma is good. The problem is that we actually don't have a lot of data on it because of the way that the initial emergency use authorization, the initial use of convalescent plasma was done, and that basically people weren't put in trials. They said, all right, well, you want to have this, you can have it. It wasn't a trial. So we're months into this. Nearly 100,000 people, I think, have received convalescent plasma, and we still don't have good data on to whether or not it works well. So the FDA decision, I think, was tough for all those reasons. The NIH apparently said, we don't have the data. The FDA will make the argument that we do have the data because it's to get an EUA, an emergency use authorization, something has to, say, may be beneficial. We know that convalescent plasma may be beneficial based on historical uses of it. I think the problem with that was that Steve Hahn stood up representing the FDA and very clearly misrepresented very bad data and tried to use it as a way to reassure us all that this decision was based on science. Right. What it was based on was a really bad interpretation of really bad data.
Was this the it'll cut 35%, it'll do,
And what he was doing there was basically, I mean, it wasn't even saying like versus a placebo control. It was people that got plasma with high antibodies versus people that got plasma with low antibodies. Okay, so you're comparing. Okay, that doesn't make sense. And then the way that he mischaracterized the absolute and the risk relative risk reduction was completely incorrect. The actual impact based on that bad data would probably be more like 2 to 3%.
And there's no way. And there's no way to tell now either, right? I mean, you mentioned this, but you didn't explain why. Tell people, why did they screw it up not screw it up. When you do the emergency use, you basically make it impossible to then tell if it works. Explain why.
It makes it much harder because basically, John, if you get sick and you go into the hospital right now and you have moderate or severe COVID, they're going to say in one or two things. If it's part of a study, they will say, hey, John, we have the study for COVID. Would you like to be enrolled? You have a 50% chance of getting a placebo. You have a 50% chance of getting convalescent plasma.
Right.
You'll say, of course, I want to be in that study because there's a 50% chance I'm going to get something that may be helpful. Right. Cool. We do that for, 30,000 Johns, and we have a really good idea of whether or not this works.
Right.
When you have an EUA, or even before the EUA, what was going on with
emergency use?
Emergency use authorization.
Authorization, okay.
Yeah. So before we have that, and we've been doing this for months, really, if you went into the hospital and you were sick with COVID, we don't have a magic bullet. They would say, hey, John, we got this medicine, convalescent plasma, that may help. We don't know. We don't have good data on it. You can either take it or leave it. Right. And you'd be like, well, okay, I'll take it. And so tens of thousands of people took it, but we didn't really compare it to the Johns not taking it. And so we don't have.
And I'm taking it with other things, by the way, too, right?
Yep.
You're putting me on my stomach so I can breathe better. You might be giving me steroids.
So we impressively found a way to use something and get no data from it.
That's the problem. Although
no good data, right?
But you were saying, Craig. You were saying it's funny. I'm pointing to Craig at the screen. You were saying, but I realized you got to tell people who we're talking to. But you were saying that sometimes if things are so bad, we want an emergency use authorization because we may unfortunately not be learning whether it works or not, but at the same time, we may be saving a lot of lives. Yeah. So you kind of give up the science.
So there are times to do it, but it doesn't sound like they were doing it in any intelligent, organized way, which seems to be what you would call a pattern for Donald Trump's entire life.
Yeah. Right. And I mean, and I do want to correct that. I don't want to imply that politics was not at all part of this decision. I think it's been clear. There was some reporting a couple of days ago in Politico, saying how Azar kind of overruled the FDA commissioner.
Yeah, they got yelled at apparently.
Some aspects of testing. Yeah. And so I think this is unprecedented in the history of the FDA. The HHS and others kind of overriding the science and really the needs identified by the FDA. That is what's concerning. And that is clearly, I think, in line with the politicization that we've seen of the CDC, of the FDA, of this response. And that is what is most concerning, because there is no reason we as a country, with an overabundance of healthcare spending and resources, with everything that we have, should have responded to this much worse than basically every other place in the world. Right. The reason was because we politicized this response from day one. We didn't work together. We pointed fingers at each other, and a lot of that came from the top.
Can I ask you just one quick thing? Because I know Well,
so much for that optimistic twist at the end.
We tried.
Well, you can tell me if I remember incorrectly. I'm just interested in this. My wife and I, so she was pregnant with our younger son at the time in 2009. Now, was that H1N1? I believe it was, but I could be wrong.
I was working in the emergency department then in 2008, 2009. That was when I first started working in the emergency room, and that was a doozy.
Right. And so and maybe because I don't remember what the need was, because you're talking about getting, distributing this vaccine to everybody and all that. We went and we got it because she was pregnant. We were considered high risk or high priority, however you'd like to put that. And so I don't remember though. Did we, in that case, need to get it out to everybody, or was it only people like us? Because it seemed like they did that once they had a vaccine relatively quickly. We waited online and for 3 hours in a parking lot of a hospital. I'm not saying it was the most pleasant experience in the world, but it was like they did it, and they did it in an organized fashion. And we still were a country even 10 years ago of 300 million people, whatever we were then. So do you know what the specifics of that whole situation were? Or no?
I would say I don't know enough. I would say I don't know enough to actually comment. I know some generalizations, but I don't know enough to use that as an example. Yeah, for sure.
Okay.
But I do want to come back and give you an optimistic twist on this.
Sweet.
I think what we've seen, it gets set up with a non-optimistic thing, but I think at the end, I think what COVID has shown us is that our healthcare system, despite being the most expensive in the world, isn't ready for the task. That tying insurance to employment is a bad idea. That systemic racism has been an issue, not just in the country, but in healthcare as well. We've seen the disproportionate impact on Black and Latinx Americans, not to the optimistic part, obviously, yet. But what I do think has happened is I think all of that has come out in a way that it is so much more palpable and obvious to so many people that all of these really horrible things that have happened or were happening and that were amplified by this pandemic are impossible to ignore, right? Like, our eyes have been open to the horribleness of all of this. And I hope that with that recognition, people are going to take this and turn this around into action. They're going to say, we need a healthcare system that is responsive and prepared for pandemics, not the one where we had torn apart our pandemic preparedness architecture in the past few years. We need a healthcare system that focuses on the needs of everyone, whether or not you're employed, whether you have a job, whether you're on COBRA. Your employment status shouldn't matter as to whether or not you should be able to get healthcare. We need a healthcare system that provides equitable care to all people, regardless of whether you're a CEO or whether you're an essential worker. I hope that coming out of this, people recognize that so many of the deficiencies that were present beforehand are still here unless we do something bold and smart and proactive to make sure that this is not the case, not just for the near future, but in preparation for the next pandemic. And I do think that recognition has happened. I do think that those issues have been amplified to a point where it is almost impossible for most people to not be aware of how bad those things were beforehand and how bad they were impacted by this pandemic.
Well, you said it before, sadly, but I will turn this into a positive thing, which is sadly that we're not preventative, and it's not just in medicine, in a lot of aspects, a lot of places, infrastructure, other things. We kind of wait till something bad happens. But our record has been that often after that, we react in a way where, even if the short-term reaction isn't the best, longer term, we get there's an issue and we move in the right direction, whether it's civil rights in the 60s, women's rights and others. So I do think you're right. I would agree 100% that hopefully it shouldn't have taken this, but this has happened now. And now that it has happened, hopefully on multiple fronts, this will lead us to a better place. So there's my positive outlook.
There we go.
All right, Craig, all right. Spencer, Dr. at, it's too long of a word. You guys all merged. I say Columbia, but was it New York-Presbyterian? Sure. In New York, Ebola survivor, COVID warrior. Thank you for joining us. Beer brewer.
That's what he wants to most be known as.
Exactly.
Hopefully again soon, beer brewer.
Absolutely. It's been a while, but I'm getting ready for it.
We'll know the world's
Cliff, John, this was great.
Thanks so much for being here, buddy.
Have a good one.
Bye.
Thanks.
Take care.
Bye.